Bismillahirrahmanirrahim. Welcome to ERA. I am Dr. Muhammad Talat, Assistant Professor of Radiology at University. I think we are almost at the end of our course. I hope you enjoyed our teaching cases. And as we did before, we started our course by CT brain checklist. And I think the most suitable way to end our course is by applying our CT brain checklist. This CT brain for an adult patient complaining of attacks of vertigo. We don't have any apparent abnormality at the CT brain. We don't have areas of fresh blood density. We don't have significant areas of vasogenic brain edema or cytotoxic brain edema. So let's apply our CT brain checklist. We should go from outside to inside. We don't have any extra exit collections. The gray-white matter interface is preserved all over the both cerebral hemispheres. The base ganglia is preserved. The ventricular system is normal regarding its configuration. We don't have any interventricular abnormalities. We don't have any midline shift. After reviewing all of these cases, we should go from anterior to posterior, from the anterior cranial fossa to check this area. And then we should start to check the sella turcica, the paracellular region. We don't have any abnormalities. Petrous apex, we don't have any abnormalities. Bones and brainstem and post-cerebellar hemispheres are normal. The fourth ventricle is normal. Basal cisterns, the circummesencephalic cistern along or surrounding the midbrain is normal. The cerebellopontine cistern on the left side is normal. On the right side, we have something abnormal on the right cerebellopontine angle cistern. So let's focus in this area because this one can explain the patient's symptom. So we have something like ice cream cone in configuration. We have specific lesion at the right cerebellopontine angle. The first possibility that we have an acoustic neuroma because we have an extension into the internal auditory canal. The second differential is meningioma, but I think it doesn't look like meningioma because meningioma should be dural-based. Our differential also includes some cystic lesions like epidermoid cyst. I think this one is not cystic. This is solid lesion. Also, our differential diagnosis may be extension from interventricular masses like ependymoma or choroid plexus papilloma from the fourth ventricle. It doesn't look like. Also, maybe an extension or excreted component from cerebellar masses like hemangioblastoma or metastatic lesions or something like this. I think it doesn't look like. So, indeed, we have a well-circumscribed specific lesion at the right cerebellopontine angle. The foramen magnum is free. The base of skull is free. All these structures are free. Internal jugular vein are free. Parapharyngeal spaces are free. So, according to our abnormalities that we described before, further MRI assessment or contrast-enhanced MRI assessment is recommended to verify possibility of acoustic neuroma. Let us move to our second case. Our second case is very interesting. This is an old patient, elderly patient complaining of dysphagia. And we are searching for a central cause explaining the dysphagia. We don't have any areas of fresh blood density. We don't have any areas of cerebral infarctions. No cytotoxic edema, no vasogenic edema. We don't have any significant abnormalities. Apart from, we have few small foci, hypotensive foci, keeping with small chronic ischemic foci at the right insula. I think we have also at the left insula and the external capsule similar areas of chronic ischemic foci. We have also relatively early ischemic changes, periventricular small hypotensive patches, keeping with early small vessel ischemic changes. We have also mild ventricular dilatation and prominence of the cortex foci. And this one is keeping with age-matched or accepted brain invasion changes. So let's apply our CT brain checklist. We don't have any extra-axis collections. The gray white matter interface is preserved. From anterior to posterior, we don't have any paracellular or cellular space occurring lesions. The basal stems is preserved apart from very small soft tissue sheet as the prepontine stern. Really, I couldn't explain this abnormality. The brainstem is normal. Both cerebral hemispheres are normal. Foramen magnum is normal. Yeah, we have here something abnormal in the nasopharynx. The nasopharyngeal wall, lateral wall, and posterior wall is markedly enlarged by heterogeneous soft tissue mass-like lesion. Even the nasopharynx lost its normal morphology. The fossa of Rosenmuller on both sides are effaced. Both eustachian tubes are obliterated. I think also the nasopharyngeal soft tissue lesion is extending along the carotid canal and the jugular foramen on both sides. I think also this soft tissue that we mentioned before may be extension for this nasopharyngeal mass. Let's move to see the bone window. Let's concentrate more on the bone window. We have some erosive changes along the skull base foramina, carotid canal, and jugular foramen on both sides. And we have also some erosive changes along the anterior aspect of the clivus. Even the skull base itself, its density appears abnormal, heterogeneous, and sclerotic. The middle ear cleft on both sides are obliterated by middle ear effusion, and this is secondary to eustachian tube obstruction on both sides. So we have here nasopharyngeal mass invading the skull base, most likely neoplastic process for clinical correlation and histopathological correlation. Also, contrast-enhanced MRI study for the nasopharynx and skull base is recommended. My question here is this nasopharyngeal mass can explain the dysphagia or the main complaint of the patient? I think yes. Nasopharyngeal mass like this, invading the skull base and invading the carotid canal and jugular foramen, especially the jugular foramen. So glossopharyngeal nerve and vagus nerve are likely invaded by the nasopharyngeal mass, and this can explain the dysphagia of the patient. Let's move to the next case. This case is very important and a challenging case at the same time. Really, I don't have the history of the patient. Non-control scan of the brain for a middle-aged female patient. Apparently, we don't have any significant abnormalities. So let's go by our checklist. From outside to inside, the extra-axial C-sub spaces are normal. But let us focus here in the left frontal region. I think all of you can agree that this area, we have loss of gray-white matter interface, especially at this region. If we change our window, check again. Also, the extra-axial C-sub spaces are obliterated at this region. And I think it is obliterated in many slices, not only in one slice. Really, this area is query. I'm not sure if this one is normal or abnormal. So once we have an area and you are suspecting abnormal features, I think you can recommend to do contrast-enhanced CT scan of the brain, or much better, you can do MRI study of the brain. We did MRI study for this case. Let's see, what did we find? We did MRI scan for the patient, and I think it's apparently now more obvious and easily detected space equine lesion at the left frontal region. And this space equine lesion is characterized by widening of the CSF space beside the mass lesion. And this one is called CSF cleft sign. We mentioned this one before. The CSF cleft sign means that we have an extra-axial space equine lesion. Also, we have an evidence of cortical buckling. The cortex is buckled beside the mass lesion. And this one is also a good sign to prove that we are dealing with an extra-axial space equine lesion. Let's see the post-contrast series. Post-contrast axial T1 weight image for the patient shows homogeneously enhancing extra-axial dural-based space equine lesion with lobulated outline. Also, we have an evidence of dural tail sign enhancement of the dural besides the mass lesion. So I think now it's very easy to diagnose this case as meningioma, left frontal convexity meningioma. Let's move to the next case. Non-contrast scan of the brain for young adult patient. We have midline mass lesion, interhemispheric indication, and this lesion shows fatty density, as you can see here. Let us review the sagittal brain. The brain, it's very clear that we have C-shaped configuration, mass lesion, or curvilinear in configuration, mass lesion at the midline, fatty density, encasing the splenium of the corpus callosum. This is a typical appearance of pericallosal lipoma. We have two types for pericallosal lipoma, either tubulonodular or curvilinear. This is a curvilinear type of the pericallosal lipoma. I think that's enough for today, and thank you so much, and see you in the next video, inshallah.